I wish I could just turn on the TV or radio sometimes and not hear that because I am Black, I am more affected by COVID, heart disease, diabetes, infant mortality, and the list goes on. Why does my race make me unable to just exist and experience equitable health outcomes? Being Black is a pre-existing health condition. During the summer of 2020, we heard a lot about racism being a public health crisis amid the COVID-19 public health crisis, where the data shows that infections and hospitalizations and deaths are affecting minorities and poor communities more than white communities. We then began to hear and see governments, nonprofits, and companies come out with statements acknowledging the problem and pledging to do something about it, including myself and a few like-minded friends. Bias, perception, stereotypes all perpetuate into the poor and inequitable care and treatment received by people of color. Racial disparities in medical care should be understood within the context of racial inequities in societal institutions. Systemic discrimination is not the aberrant behavior of a few, but it's the institutional policies and unconscious bias based on negative stereotypes. This type of bias is called implicit bias. This is where physicians and med students automatically stereotype patients based on external factors. Medical school does not teach students to recognize their own implicit bias. So, combined with medical text being written with implicit bias, or just simply ignoring altogether persons of color, this adds significantly to the disparities in the healthcare received and at disproportionate rates. Racism is a public health crisis. The connections between race and health are complex and interwoven. However, the research is clear that racism is a primary driver of inequities and disparities experienced by communities of color. In Dayton, Ohio in 2019, I have a friend and we'll call him Larry. Larry was experiencing a sore throat and swelling that obstructed his breathing, and Larry was admitted to the hospital and placed on IV pain meds. Larry rated his pain at a 10, and after 4 days, his pain level was still at a 9. The nurse practitioner said, "Well, it's not a 10, so we're probably going to discharge you home on Advil." Larry expressed his concern about it. It was then that the nurse practitioner asked him a series of questions. After learning that Larry was a middle-class bank manager of 2 bank branches, the nurse practitioner determined he was not ready for discharge and consulted the attending physician about proper adjustment of meds. The issue here was the bias and perception of the provider versus the real picture of Larry's needs. Doctors are 10% less likely to admit Black patients to the hospital via the ER, and Black patients are 126% more likely to die because of provider neglect, disbelief, and/or active discrimination. Inequities can be associated with poor health impacts on communities of color, including widespread misdiagnosis of conditions and disease, overdiagnosis of severe mental health disorders, high maternal morbidity and mortality rates, high infant mortality rates, high rates of chronic conditions, and exposure to toxic pollutants. On top of not being believed, patients of color face additional profiling in terms of assumptions built on stereotypes. I was checking on a colleague's wife who had just had a baby via C-section. A little backstory here. My colleague is a physician and was present for the birth and present the entire time. He was just not in the room at the time this incident occurred. So, the nurse comes in to check on the new mom and immediately says verbatim, "So, is the baby's father going to be involved in the child's life at all?" I can't say on stage all the things that immediately ran through my mind to say to this nurse. The mom spoke up and said, "You mean my husband, Dr. So-and-so?" The nurse said, then replied again verbatim, "Oh, you're married?" At this point, I'm making an immediate call to her husband and tracking down nursing leadership. The nurse never apologized for her ignorance and left the room. Now, remember I said that the wife had a C-section, and with a C-section comes pain. Never did the nurse once ask about her pain or check her wound. By this time, my colleague was arriving and indicated that his wife was in pain and needed meds. There was reluctancy to the point where the OBGYN had to be called to make the nurse give the medication. In fact, because medical schools and textbooks focus on Caucasian bodies by default, birth and C-sections are especially problematic for pregnant Black women. As a result, healthcare providers don't give time or thought to studying other body structures. If you recall, Serena Williams, during her labor and delivery, experienced health issues that she tried to explain to her providers while in labor. Women know their bodies and health histories. Again, because of the widely held belief amongst white providers that Blacks have a higher tolerance for pain, and 73% hold at least one false belief about biological differences, Serena almost lost her life. And on another note, because Black women patients during labor and delivery receive inequitable care, 80% of Black women are readmitted after delivery. This rate would be much lower when proper care is given pre-delivery and after delivery. Awful, right? This honestly happens more than I can quantify. I worked in the hospital system for over 8 years and witnessed these inequities on each shift at least once. Hopefully, you are beginning to see the how and why. These are real-life stories, stories of fellow Ohioans. So it's not like this is occurring somewhere else. It is, but it's a frequent occurrence in our own backyard. So, what do we do? You may be still trying to process the stories. They are significant and sadly real. In order to solve the problem, a true and comprehensive approach to health equity requires addressing both social and delivery system factors driving inequity. We must solve for clinician bias, as well as limit the impact of social and economic factors on health to fully address disparities and better serve vulnerable populations. Marginalized populations become marginalized patients through the expression of social factors and delivery system failures. Our healthcare system must take ownership of its contributions to the problem. The reality is that healthcare is staffed by individuals who are subjects and purveyors of various social constructs and beliefs, both positive and negative. Bias and prejudice are as much a part of the healthcare culture as in the general population. Academia and delivery systems must strive to be better than the current sum of our parts and no longer reflect some of the greater shortcomings of our society. Today, being Black in America is a pre-existing health condition, but it doesn't have to be.